Good morning, dear patient, dear colleague, dear friend. Today I will have a special topic, something we don't see very often in gynecology, but also in neuropelveology, and it's what we call pelvic schwannoma. I took the decision to talk about the pelvic schwannoma because last week I saw a patient coming from abroad with such a pelvic schwannoma. And this tumor was well known in this patient since more than 10 years. So, and she was a little bit, no, not just a little bit, she was completely lost because nobody more or less were aware what to do. So let's talk about this special issue we call the pelvic schwannoma or the schwannoma of the pelvic nerves. So the first thing is, what is a schwannoma? A schwannoma, it's a benign tumor. That is the first point. It's not a cancer. It's a benign tumor that develops from what we call the Schwann cells. The Schwann cells build the tube surrounding the axon of the nerves. So it protects the nerve from everything coming from outside. And for some reason, nobody knows exactly, such kind of Schwann cell may start to grow and build a tumor, a lump called schwannoma. And usually schwannoma grows very slowly over years. It's not something like an endometriosis of the sciatic nerve, which will take 1-2 years to start to destroy a nerve. No, a schwannoma, at some point, that is for sure, will start to destroy the nerve, but it can take 5 years, 10 years, or even longer. Schwannoma, a tumor, benign tumor for the nerves, and can appear almost everywhere in the body. You can have in your brain, you can have in the spinal cord, you can have in your abdomen, in the leg, in the hand, everywhere where you have nerve, mean everywhere, you can develop a schwannoma. But we have to be aware that schwannoma are very, very, very rare. I performed probably the first laparoscopic resection of a pelvic schwannoma for in the world for maybe 15, 20 years. And over the last 15, 20 years, I performed a little bit less than 30 schwannomas, the surgery for 30 schwannoma. So you see, it's very, very seldom. If you compare, I performed more than 200 laparoscopic nerve decompression for vascular entrapment over the last 2 years. It took me 25 years of my life to get a little bit more than 500 endometriosis of the sciatic nerve, which is a very seldom form of endometriosis. And it took me exactly the same time, 25 years, to get 30, a little bit less than 30 schwannomas. So that is very, very seldom. But the problem of the schwannoma is the pelvic schwannoma. That is a very, very special entity because they are not located somewhere in the body, which is easy to reach for diagnosis, for palpation, for biopsy, for everything, for surgery. No, it's located within the pelvic bone, within the pelvic cavity. That is the first issue. The second issue, between the pelvic bone and the big and large major pelvic vessels. That means the access to this nerve is very difficult from outside because of the pelvic bone, and very, very dangerous because of the risk of huge bleeding. And that is one of the reasons also why the diagnosis is made usually very, very late. The symptom of a schwannoma of the nerve, I cannot tell you you have this or this symptom because it will depend which nerve. So the symptom, because the tumor develops very, very slowly, the symptom will progress very, very slowly. And we are talking from neuropathic pain. That means burning pain, tingling pain, electrical shock, such kind of feeling. And where will depend from which nerve. So when we are talking from the sciatic nerve, the patient will develop deep back pain, gluteal pain, sciatic pain, leg pain in the back. If you are talking from the lumbar plexus, the pain will be located in the legs as well, but in the front, not if the back, like in the sciatic nerve. And if suppose this affects the sacral plexus or even the pudendal nerve, the patient will develop pudendal pain, mean combination or maybe only one of the symptoms, genital pain, perineal pain, perianal pain. And of course, the pain will get worse in any situation when you have a compression of the nerve or when you have a stretching of the nerve. So the pain may increase when patient is standing or may increase when the patient is sitting. It will depend once again from which nerve is affected and in which location within the pelvic cavity. So the symptom, of course, patient will develop neurological deficit early or late. So you have the sensory and the motor trouble. The sensory symptom, the feeling symptom, I mentioned previously, is what we call paresthesia. So tingling, pin and needle, burning pain. And at some point, when the schwannoma will start to compress enough the nerve to induce neurological disorder, the patient will even develop numbness in the area where she feels pain. So if suppose the patient had pudendal pain, at some point she will develop a numbness or at least a decrease of the sensation in what we call the dermatome. That means the area of the pudendal nerve, means the vulva, the perineum, and the perianal area. If the schwannoma is located on the sciatic nerve, the patient will feel weakness, paresthesia, numbness, or hypoesthesia in the lower back, in the bottom, or in the dorsal aspect on the left. The nervus obturatorius will be in the inside of the thigh, while the femoral nerve will be in the front of the thigh. And then the patient will early, that is for sure, she will develop at some point motoric disorder as well. So, but motoric disorder, because within the nerve, the motor fiber are a little bit bigger in diameter than the sensory. The schwannoma will first affect the sensory fibers and much later the motoric fiber. But then you will be more or less able to make the diagnosis even when the patient is coming in your office, because she will develop a foot drop, she will develop a hamstring weakness, a Tredelenburg gait, a weakness of the quadricep, means the extension of the knee, difficulty for climbing stairs with loss of the dorsal or the plantar flexion of the ankle. She will have a loss of the reflex, Achilles, or the patellar reflex, always depending from which nerve is affected. And there is another form of schwannomas. It is even more seldom. It's a schwannoma not of the somatic nerve, like the sciatic nerve, obturator nerve, pudendal nerve, but of the autonomous nerve, the vegetative nerve, which are located in the middle of pelvis, around the cervix, the vagina, and the bladder. And then this schwannoma will induce in a first stage an irritation of the nerve, so the nerve of the bladder. The patient will develop urinary emergency. On the late stage, once these nerves are starting to be destroyed by the schwannoma, she will develop bladder retention. In exactly the same with the rectum, she will develop a colon irritabilis in the beginning, and in a later stage, she will develop a constipation. And of course, when you have a lesion of the pudendal nerve, it's the same. Patient will, in a late stage, develop a urinary and a fecal incontinence. So why we have always to perform surgery for schwannoma? Because it's incredible, but I saw in the past some patient coming from abroad with schwannoma, where some colleague mentioned the patient, oh, it's a benign tumor, so it's no need to do anything. Simply wait, and once the schwannoma will have fully killed your nerve, then you will not feel pain anymore. And in my opinion, that is definitively not a solution to simply wait until the schwannoma destroys the nerve. So we have definitively to perform surgery for the reason number one, prevention of neurological symptoms. I told you that it will start with pain, then you will start to develop neural sensory disorder, and then motoric disorder. So it's no need to wait until you get trouble with walking motion. It's no need to wait until you cannot empty your bladder or until you will develop the incontinence. No, it makes no sense to need, because without removal, the schwannoma will sooner or later cause neurological problem. For sure. You will develop the neurological disorder. And it's exactly what the colleague said. If you wait too long, the schwannoma will finally fully destroy the nerve, and then maybe you will feel less pain, but you will have a fully loss of the function of these nerves. That means if this nerve was in charge of the sensory function of the genital area, then your vulva is fully numb for the rest of your life. Or if the schwannoma was affected, the sciatic nerve, then you will have difficulty for walking. Probably you will have to use a crutch for the rest of your life. The second thing, pelvic schwannoma are very special because they are in the pelvis. And in the pelvis, of course, you have the bone, you have the vessel, but you have also the bowel, you have the ureter, you have the bladder, you have a lot of things. So if a schwannoma is still growing and start to compress pelvic vein, then the patient may develop pelvic thrombosis. Pelvic thrombosis is a life-threatening situation, because if you get from this pelvic thrombosis pulmonary emboli, you can die from that. So close to the sacral plexus, to the main pelvic nerves, you have the ureter. So if the schwannoma over months or years is starting to compress the ureter, you will develop what we call an hydronephrosis, or a ureter dilation. If the urine is not passing the right way through the ureter, you will have a high pressure in the kidney, and over the years, this ureter dilation will kill your kidney, and you will develop hypertonia. So if the schwannoma kills the nerve of your bladder, you will be not able to empty your bladder. So you will have to go very, very often on the toilet to pee. We can call that urinary or urgency, but not because you have an overactivity of the bladder, but because you are not able to pee. And in this situation, you would have to use a catheter to empty your bladder, and this for the rest of your life, because once a schwannoma destroys nerve, it's forever. The nerve will not recover, it will not grow again. That's the reason you have to remove this schwannoma before you have a fully destruction of the nerve. And when you have a compression of the rectum, of the bowel, at the early stage, you may develop some constipation. But if the schwannoma is getting very big, and sometimes it's appear, I already removed schwannoma from 7-8 centimeters. It's a big pelvic mass. And such a big pelvic mass, especially on the left side, if you compress the rectum, patient may even develop some intestinal stenosis. And that is a very, very severe complication as well. The third reason why we have to remove the schwannoma, the risk of malignant transformation. And we are aware that this risk is very, very low. Less than 1% of the schwannoma will become a malignant. Yes, it's true. But we have no possibility to find out if a benign schwannoma at some point will change in a cancer. We don't know. We don't know when it would transform in a cancer. And more than that, we have no diagnosis for that. You cannot make every year a biopsy from outside. You cannot pass with a needle through the bone and to make a biopsy of the schwannoma every year. Even more, remember what I told. You have major pelvic vessel around the nerve. So if you have a puncture with your needle of the major vessel, then you can lose your patient because of a blood loss, because of an hemorrhagia. And the second point is that the patient in who schwannoma will transform in a malignant, in a cancer, this patient will probably die from this. Then we are not talking that schwannoma, we are talking that malignant peripheral nerve sheath tumor, MPNST. And these tumors are very, very aggressive, developing very, very early metastasis in the rest of the body, with, of course, as consequence of that, a very poor overall survivors and very, very high rate of recurrence. Every schwannoma may develop a cancer, but we know there are some risk factors like previous radiotherapy and what we call neurofibromatose type 1 that are risk for benign malignant to transform in a malignant, in a cancer. So the challenge of the diagnosis. First, misdiagnosis. Most of my patients I saw over the last 20, 25 years coming in my office with a schwannoma got the diagnosis over years: ovarian tumor, uterine fibroid, or myoma, pelvic mass, enlarged lymph node, whatever, but not the diagnosis of schwannoma, probably because, number 4, the lack of awareness among pelvic specialists. I know that when I'm doing the workshop in neuropelveology level 1, level 2, sometimes even some colleague gynecologists ask me, what are you talking about? Schwannoma, what is that? Schwannoma, the word is even difficult for them to pronounce because they don't know this word, this pathology. And many ObGyn, urologists or colorectal surgeons are not familiar with such pelvic schwannoma because they are even very rare. So nobody in the normal field of gynecology, urology, or colorectal surgery, we will be able to say, I have a big experience in surgery for schwannoma because it's very seldom. Probably most of the gynecologists will never see a patient with a pelvic schwannoma in their life. And secondly, if you have seen maybe 1 or 2 schwannoma in your life, you will be not trained in the surgery of the schwannoma, just by the way. So it's very difficult and risky to get a biopsy. Usually, when you see a tumor like here, you see on the MRI, the picture below is on vaginal. By vaginal route, you can reach most of the pelvic schwannoma, and you can check with Doppler is there some neoangiogenesis, some blood supply within the schwannoma. In this patient, you see there were no blood supply within, so it was definitively a schwannoma. But if you see in Doppler and sonography a lot of blood vessel inside, that is really a high thing for a malignant schwannoma. The MRI here, you see the picture, the picture on the top. That is a schwannoma from the sacral plexus, and you see pretty well is separated from outside through the skin, the entire bottom muscle, and the pelvic bone. So it's very, very difficult to take a biopsy from there on minimal way. And of course, you have risk with a needle to induce damage of the nerve, and of course, damage of the surrounding vessel with a risk of huge bleeding, risk for hemorrhage, which can be really life-threatening for the patient. Why surgery? Just to coming back, the radiology expertise is the same. The radiologists who want to give an interpretation of the picture have to be really experienced in pelvic tumor and in schwannoma, just by the way. Why surgery is challenging? So pelvic schwannoma, usually patient with pelvic schwannoma will end up in a department of neurosurgery, not a department of abdominal surgery or gynecologic surgery or urology, for sure not. We are trained in laparoscopy, vaginal, and open surgery. But neurosurgeon, who usually sees the patient as first, are trained in open surgery, but coming from behind, from the buttock. So traditionally, neurosurgeon, when they try to remove a pelvic schwannoma, they are using a large open incision from outside the pelvis, usually at the level of the buttock, and need to cut all the bottom muscle, the gluteal muscle, and the bone they have, because the tumor is on the other side of the bone. And the fact to have resect part of the bone makes that this procedure is very, very traumatic, even more because when you cut the bone, you have the risk, of course, of bleeding. And usually, when you cut pelvic bone from outside, most of the neurosurgeon will get a bleeding. And secondly, you have a risk or lesion of the nerves just behind the pelvic bone. And of course, such surgery are very, very traumatic and large surgery. So patient will need a very, very long recovery with difficulty for working function. And suppose she develops some scar tissue in the bottom, secondarily, she can develop a fibrotic entrapment of the pudendal nerve with neuropathic pudendal pain and so on. That is a situation I observed several times in my career. So neurosurgeons are expert in operating nerve, but more in the much more accessible nerve of the upper limb, or in the spine, or in the brain. But pelvic nerves are definitively different because they are located within the pelvic cavity and protected from outside by the pelvic bone, which is a big bone. The pelvic nerve are surrounded by very delicate organs, ureter, bowel, bladder, depending from which nerve we are talking about, and of course, blood vessel. And that is probably the main risk in such kind of surgery. The main risk is not to kill a nerve, you can do that, but the main risk is a risk of lesion of the blood vessel. And that is really a serious risk because you can even lose the patient during the surgery, so due to a massive hemorrhage. Third, the standard neurosurgical procedure is using a microscope. A microscope is a device from 1.5 to 2 meters in the height and very well designed for nerve you can approach from outside. But neurosurgical microscopes are definitively not designed for the deep and narrow space where the pelvic nerve are located. So you can forget it the normal neurosurgical way. And that's the reason why for more or less 20, 25 years, I was the first to use a laparoscopic approach to remove a pelvic schwannoma. At that time, it was a schwannoma from the sacral plexus on the left side. And of course, the use of laparoscopic procedure permit precision. We have the right instrument to remove a schwannoma. We have the optimal vision and magnification in the structure. It's like a microscope you bring within the pelvic cavity. And of course, it's a minimal invasive surgery, so the patient will have a faster recovery. But and that is really the big problem of the surgery of the schwannoma. It's not just you get an MRI, you know where is the tumor, it's on the left, I'm a good surgeon, let's go there and remove the tumor. If you do that, you expose the patient to a very, very high risk of nerve lesion and vascular lesion. In schwannoma, you don't need just to know where is the tumor on the left, on the right, on the middle, in the front or in the back. But with a neuropelveological diagnosis, you will be able to find out from which nerve, exactly which nerve, in which exactly position within the pelvic cavity you have to find the schwannoma. Because you have to do what we call an enucleation. You cannot cut part of the schwannoma. You have to remove the schwannoma in one piece. And the first things during the surgery is to secure the procedure. And secure the procedure means to control all the vessels surrounding the tumor. So you need definitively a neuropelveologist with a high experience, first in vascular surgery, or you have to have a vascular surgeon in the OR, which is a little bit tricky because vascular surgeons are not trained in laparoscopic pelvic surgery. But that is the most difficult, the most dangerous vascular injury. So before removal of schwannoma, you have to secure all vessel around the tumor. Maybe you have even to cut most of the vessel, which you can remove in order to make your surgery safe. So you neuropelveologists need to know the exact anatomy of all pelvic vessels. You have to be an oncological surgery. You cannot do surgery like an endometriosis, you cut apart. Oncological surgery means you will remove the tumor in one piece, what we call en bloc, and best with some margin free. Of course, because schwannoma develop from the nerve sheath, you cannot resect the nerve. So that is what I said before. You have to know before you start surgery from which nerve the schwannoma developed. Then you have to dissect this nerve, and usually you have to open the nerve and take the schwannoma out of the sheath of the nerve. And that is what we call neurosurgery or microneurosurgery. So your surgeon have to be a vascular surgeon, an oncologist, a neurosurgeon, and at least you have to be trained in advanced laparoscopic pelvic surgery. You have to be an oncologist or at least an endometriosis surgeon, but an endometriosis surgeon in the retroperitoneal space, and at best to an endometriosis surgeon to the pelvic nerves. So you see what you need is not a gynecologist, a urologist, a colorectal surgeon, or a neurosurgeon. You definitively need a neuropelveologist with long experience with this kind of surgery, and best with knowledge in vascular surgery, in oncological surgery, neurosurgery, and pelvic advanced surgery. And that is probably the reason why I start with such kind of surgery, because before I become a gynecologist, I was a cardiovascular surgeon. I was trained 6 years in cardiovascular surgeon. I'm in the field of gynecology. I'm an oncological surgeon. I'm trained in cervical cancer, shorter procedure, and lymphadenectomy. I'm a laparoscopic surgeon. I'm trained in retroperitoneal endometriosis surgery. I'm trained in retroperitoneal nerve surgery. So over the last 25 years, I built myself to become a neurosurgeon on the pelvic nerves. So you see, schwannoma is not just, oh, I see a beautiful picture on the MRI, try to go there, I'm probably one of the best surgeons, do it. No, you need much more than that. Otherwise, you will kill the patient, you will kill the nerve, or you will get a big complication, or you fail during the surgery, you will be not able to remove the tumor because of some surgical difficulty. And that is the worst what can happen, because you have to make enucleation of the tumor. So if somebody try to remove the tumor and stop the procedure because of some difficulty, the second surgeon will find a lot of scar tissue, and it will be very difficult for him to find the proper cleavage plane between the schwannoma and the rest of the normal pelvic tissue. So I thank you very much for your attention, and remember, pelvic schwannoma are very rare, but can be successfully treated by a very experienced neuropelveologist. Thank you very much for your attention. Keep healthy, and we are in summertime. I wish you maybe a very beautiful holiday. See you in several weeks for the next education lecture for patients. Thank you so much. Bye-bye.